Good morning, everybody. Thank you for joining us today. We'll get started right away. I will introduce our regional primary care lead, Dr. Becky Ray, who will get us started. Thanks.
Thank you, Sarah. Welcome to everybody today. Thank you for joining us. It was World COPD Day, as everybody knows, on Wednesday, or maybe you didn't know, on Wednesday. And so we are excited to bring some updates to you today around the Ontario Lung Cancer Screening Program. We're lucky enough to have with us Dr. John Dickey. Dr. Dickey is a thoracic surgeon and surgeon-in-chief at Lakeridge Health. Dr. Dickey, throughout his career, has held a number of provincial and national leadership roles in thoracic surgery and was the clinical lead for the high-risk lung cancer screening pilot at Lakeridge Health, and is here to speak to us about the Ontario Lung Cancer Screening Program. So without further ado, I'll hand it over to you, John.
Thanks, Becky. And thanks to Sarah for asking me to talk today. I'm just going to share my screen, make sure this works. People can see that, I hope. Great. So I do need to right up front acknowledge OHCCO for preparing the slides for the presentation. I can't take credit for that. So thanks to them for providing all 70 odd slides. And what we're going to talk about today is lung cancer screening for high-risk individuals, and specifically the Ontario program that's evolved over the last 7 or 8 years. Sorry, I'm having trouble. And there we go. Up front, I have no relationship with financial sponsors, sadly, and I have no potential conflicts of interest. And the program similarly has not received any financial or in-kind support. This is a disclaimer, again, provided by OHCCO, that the program is not the opinion of the speakers, myself and others, but uses evidence-based content provided by OH. And this is an important slide to talk about using inclusive language, specifically gender-neutral language in documents like these, to ensure that every individual who could benefit from screening feels included and comfortable accessing it. So today, as we go through this, and there'll be time to ask questions at the end, I hope, we plan to describe the evidence for screening in people at high risk, and specifically how that has been implemented and applies in Ontario. Look at the benefits and harms of lung cancer screening, outline the steps specific to the Ontario lung screening program, and try and identify and help you identify people who should or should not be referred. So specifically, we'll look at the burden of lung cancer and the evidence supporting the benefit of screening. What that process looks like in Ontario, specifically the referral process, the smoking cessation component of it, the technical aspect of the screening scans and the communication of results, and also the communication processes or the recommendations about talking to patients about screening and other issues around lung cancer and screening. So I think all of us are aware of this. Lung cancer is an enormous problem. It was the leading cause of cancer death in Ontario in 2024 and has been for as long as records have been kept. And specifically, it was projected to account for 22% of all cancer deaths, much higher than the actual incidence of diagnosis. And unfortunately, most lung cancers historically have been diagnosed at stage 4, where the outcome is abysmal. And screening is important because it is designed to find cancers at an early stage And we know that cancers diagnosed at an early stage are associated with much better outcomes. And like many other public health problems in Canada, this is a particular issue in First Nations, Métis, and Inuit. Indigenous people have a much higher prevalence of smoking, a higher incidence of lung cancer, and a poorer outcome from diagnosed lung cancers. And I would say that the program has focused very specifically, or tried to, on Indigenous populations right from the beginning, to try and make sure that they can access the benefits of screening as effectively as possible. So just to start talking about screening, then, I think it's important to talk about the difference between organized cancer screening programs and opportunistic or ad hoc screening. I think that opportunistic screening has been happening and for years prior to the implementation of the organized program in Ontario, because primary care providers like yourselves understood that there was benefit to it, because the evidence for the benefit has long predated implementation here in Ontario. But the differences are important because the outcomes differ depending on how patients are screened. So organized programs are run centrally and have very clear algorithms and policies around the process and what to do with findings. The process is evidence-based, and in Ontario, tracked very carefully to measure quality, performance, and opportunities for improvement. Opportunistic screening occurs outside of that, as we talked about, and it usually happens when individuals come to their primary care providers asking for screening, or the primary care provider recommends it, but either can't access an organized program or haven't been able to, or want to pursue that locally in a site where the program isn't available. So OH advises against opportunistic screening, and the reasons are that it is well known that screening, especially for lung cancer, or particularly for lung cancer, is associated with potential harm basically at all steps along the process. So it's important to make sure that patients are getting the proper type of screening scan, specifically low radiation dose scans. And oftentimes ad hoc screening involves diagnostic CAT scans with higher radiation dose. They often include IV contrast, which is not necessary for screening. And the algorithms or processes to deal with follow-up testing for positive findings are not as well defined, depending on what processes are accessed. And specifically, it can lead to unnecessary further investigations, including invasive testing like biopsies, which do come with risk. So in an organized screening program like the OLSP, lung cancer in general, and this isn't unique, this applies to screening in general, lung cancer can be found at an earlier stage where it is more effectively treated. But organized programs ensure low-dose CAT scan rather than diagnostic CAT scans. It ensures standardized reporting of results to primary care providers and others, and provides specific follow-up recommendations for findings to try and reduce the risk and harms associated with false positives. Embedded in the Ontario program is direct access to smoking cessation. And if there are suspicious findings, the organized program ensures access to a lung diagnostic assessment process to work up those findings. So there are harms, though, and I'm sure you're all well aware of the general harms of screening. Specific to these is low-dose CAT scan does involve radiation exposure. That exposure is small, It is on the same order as a chest X-ray, but repeated annual scans could theoretically cause adverse effects like secondary cancers. That is a controversial point, but we have to acknowledge that's a consideration. And even in organized programs, false positives are a significant issue that needs to be mitigated. Most of the findings on screening scans are not cancer. So, and we do know that these positive findings cause stress for the patients, anxiety about what that relates to, could potentially lead to those unnecessary diagnostic assessments I mentioned before, up to including lung resection. And screening itself in general can lead to overdiagnosis, which is the notion of identifying cancers that would not have been clinically significant or clinically important if they hadn't been detected through a screening process. So what the Ontario program has tried to do is minimize these risks or mitigate them through a variety of approaches, but perhaps most specifically by using a more robust risk prediction model to decide who should get screening. So these prediction models are designed to identify individuals who are at increased risk for lung cancer, and such that the risks of screening are outweighed by the risk of developing the disease. And they do lead to more accurate screening results, higher positive predictive values. They do improve outcomes. They've been shown to improve outcomes. It leads to lower numbers of people needing to be screened to avert death. And overall, they are more cost effective, obviously very important in a publicly funded healthcare system. So the evidence to support this, and we'll talk about it a bit more, has been there and been compelling for on the order of 14 or 15 years. It did take quite a while to have this started and established in Ontario, but in 2017, a pilot was launched in Ontario to look at how best to implement an organized lung cancer screening process. This pilot continued for 4 years and transitioned to the Ontario Lung Cancer Screening Program in April of 2021. And all of the lung cancer screening hub sites, when we'll talk about what that means in a minute, are thoracic surgery centers that include diagnostic assessment programs for that transition for patients who have suspicious findings through to a diagnostic process. So this is the current state of screening in Ontario in terms of accessibility. So you can see that there are now a number of sites. In 2017, there were 3 that participated in the pilot. That included Ottawa, Health Sciences North in Sudbury, and us at Lakeridge. And one site, Ottawa, actually very early on included a spoke site. So that is a hub and spoke model. Specifically where the administrative and navigation elements of the screening program are handled at a hub site, and we'll talk about that again in a minute. But the scans are available in a spoke site, and in Ottawa, that original spoke site was Cornwall. You can see that there are other sites now that have spoke sites. So the other sites have implemented the hub and spoke model, and we're very pleased that just this month, Ross Memorial Hospital has joined us at Lakeridge as a spoke site, and has been live now, or is live now for starting actual screening. So we're very excited about that. But I think it's important to point out that accessibility, depending on where individuals live, is improving, but still remains a challenge. And I think it's safe to say that improving accessibility, increasing the number of sites is a priority for the program going forward, whether that's new hub sites or increasing the number of spoke sites for existing hubs. So in terms of the design of the OLSP, there are a number of elements, and we'll go through each of these to some degree. So the first is recruitment, which includes provider primary care education, as well as public recruitment and education strategies. An initial risk assessment for patients who qualify for the very broad eligibility for screening. And that risk assessment involves the use of that risk assessment process I mentioned before. The OLSP includes robust smoking cessation strategies for everybody who comes in contact with the program. A organized and very well-defined radiology low-dose CT process, and then a facilitated seamless transition to diagnostic assessment for patients with suspicious findings. So in terms of the process initially, so the primary care provider completes and submits a screening referral form. That's how the vast majority of patients access screening. It's very important to note, though, that the eligibility to be assessed is very broad, and not everybody who has been referred will end up being eligible for screening. And that gets to the risk assessment, which is performed at the hub sites by a screening navigator. And again, using that risk prediction model. And at this point, smoking cessation access is ensured for everybody who currently smokes who comes to a risk assessment, including those that aren't eligible ultimately for screening. And then if eligible, there is a screening visit to discuss the benefits, potential harms and limitations of screening, the schedules, et cetera. And then there is ongoing smoking cessation support. So we'll get into more detail, but in broad terms, if patients are eligible for screening and undergo that, it involves a low-dose CAT scan. And the low-dose CAT scan generates two broad types of categories of results. One are those specific to the lung cancer screening itself, which involves a risk stratification based on findings, and then a follow-up recommendation based on how suspicious those findings are, ranging from routine annual reassessment through to repeat CAT scans at varying time intervals, again, depending on findings, or for very suspicious findings, referral to a lung diagnostic assessment for workup of a suspected or suspicious lung scan. The other category, though, are the incidental findings. So it was well recognized in all of the studies and trials looking at lung cancer screening that because you're doing a broad test, specifically CAT scan, that there will be incidental findings unrelated to the risk of lung cancer. And the primary care provider, the referring provider, is responsible and accepts responsibility for follow-up of these incidental findings. And we'll talk more about that as well. So as I mentioned, the actual triage criteria are very broad. They're actually broader than the trials that have been used to look at benefit, and specifically anybody aged 55 to 80 who have smoked cigarettes for at least daily for at least 20 years, and not necessarily in a row. So 20 years total are eligible to be assessed for screening. Now, the other pathway to access screening is through self-referral. So individuals can present to a hub site or a spoke site, I would imagine. I'm not sure about that part, I must admit, to be assessed for screening eligibility. And that initial decision about whether they meet this broad triage criteria would be made by the site they present to. And then the next step is risk assessment. So that's done at the site and is offered to everybody who meets these broad criteria. But the risk assessment really does focus on higher risk populations to actually offer screening. And so again, it's important for patients and providers to know that not everybody who gets referred will end up getting screening. It depends on whether the patients, the individuals meet the risk assessment criteria. Now, having said that, what became very clear in the pilot early on was that the majority of people do meet the criteria. So that, and actually, I think it's safe to say that the pilot participants, meaning the organizers, were surprised at how high the inclusion rate was from initial referral. Over just about 2/3 of patients who were referred ended up being eligible after risk assessment, which was higher than anticipated. Now, those who shouldn't be referred are those that have been diagnosed with lung cancer. They do need, if we're going to do surveillance on those patients, that needs to be a different pathway. Those who have known lung nodules, have symptoms suggestive of lung cancer or concerning for lung cancer, and those for whom medical comorbidities and other issues make it likely not beneficial to be screened. So there are various ways to interpret that. I think, one way that we look at it is if a patient is so unwell that they would likely not be a candidate for lung cancer treatment, at least not conventional treatment. If a cancer was found, then that we should seriously consider whether screening is of benefit. This is the form. I'm sure many of you have filled it out already. And by filling out the form, providers authorize the use of low-dose screening CTs. Again, that would be discussed with patients through the screening site as well. They authorize the booking of these scans, and they authorize the referral to a lung diagnostic assessment program if patients have suspicious findings. So that transition from screening to a diagnostic assessment process happens without you needing to submit a referral as primary care providers, but that referral is under your authorization. And the other thing providers commit to is ensuring the appropriate follow-up of incidental findings on the low-dose CTs. So this is the risk assessment broad questions. We actually use a risk assessment tool that was designed and championed by a Canadian from Brock University, Martin Tamamagi, and this assessment tool is now recognized around the world. And it looks at a number of characteristics of individuals to try and further stratify their risk of developing lung cancer to ensure that screening is of benefit and that the screening benefits outweigh the screening risks. And this risk assessment is designed to define people with a 2% or greater risk of developing lung cancer in the next 6 years. And again, if an individual has that risk, 2% or greater, then it is felt that that screening is of benefit and that benefits outweigh risk. So again, not everybody who undergoes risk assessment will end up having a 2% or greater risk. We know it's about 2/3, but that means a third don't. And that doesn't mean they can't access screening in the future. In terms of re-referral recommendations, if a patient's risk score is under 1%, they can be re-referred 3 years later for another risk assessment. 1 to 2% can be re-referred immediately if they had stopped smoking and start again. If they are diagnosed or have a new diagnosis of COPD or a new family history of lung cancer. If none of that happens, then they too obviously could be re-referred at 3 years, and over 2% or over are eligible for screening and would be enrolled. So again, the two pathways are provider referral, and the vast majority of individuals are referred by primary care providers. And then the self-presentation route, that does happen. And these patients present to a site without a referral. So the site will conduct the initial triage assessment and then the risk assessment. The site will also send a request letter to the patient's primary care provider if that patient has a primary care provider, and ask for a referral letter. A referral letter needs to be provided. And again, if that individual has a family doctor or nurse practitioner, that would come from them after a request from the site. If that individual does not have a primary care provider, the screening site is responsible for providing support for that, specifically identifying an individual who is able to submit a referral and an individual who commits to following up on incidental findings from the scan. And I do need to acknowledge that Becky is that individual for the entire local screening program. So she's owed a huge amount of gratitude for that work, because it allows people, specifically those without primary care providers, to still access the benefit of screening. And so this is just again a summary of the responsibilities for unattached participants. It's important to point out, though, that although Becky will provide the specific support for the screening program, this is not a family physician. They cannot obviously take on responsibility for comprehensive primary care, but will support the initial referral process and the follow-up of incidental findings. So in terms of informed participation, it's important that potential screening participants know about the risks we touched on initially. So after eligibility is defined, the site will provide an overview of potential benefits and harms to the participant, and we'll also provide an information sheet to facilitate conversation about all of the elements that could be of concern, including radiation exposure, what happens with results and what the next steps would be, what the benefits and harms of screening are, and very importantly, what the expectations are around smoking cessation support. So in terms of that, smoking cessation support is offered to everybody who touches the screening program, not only those who are ultimately eligible. Those who are eligible end up accessing, if they choose to, a robust site-based cessation program. And those who aren't are referred to the provincial programs that support smoking cessation, including Health 811. And I'm sure you know this, that the resources available centrally are actually quite effective. So again, even if ineligible, patients are given information and are encouraged to pursue smoking cessation. This, again, is a particular issue for Indigenous people. So, it's well recognized that that the chances of a particular group accessing supports and services depend on a number of factors, including whether that support is culturally appropriate. And this particular program, Talk Tobacco, does try and provide that for First Nations, Inuit, and Métis. And that can be through phone, text, and live chat. And it also provides access to smoking cessation medication, specifically nicotine replacement. Another program that involves what's called tobacco-wise leads offer that same sort of support, including frontline support to Indigenous community members and health staff. And again, these are all accessible online. So in terms of the low-dose CAT scan, so low-dose CTs, as the name would suggest, involves much less radiation exposure than a diagnostic CAT scan and does not require contrast. It's very important that patients who are undergoing potentially annual screens for 25 years or so, that these individual scans are low dose. Patients will get their screening results and next step recommendations within 2 weeks. And the reporting includes a standardized, what's called LUNGRADS reporting template for the reporting of lung nodules, and then the incidental findings as we talked about. So LUNGRADS stands for Lung Screening Reporting and Data System, and it's a standardized reporting template for radiologists to communicate findings related to lung nodules. And it allows everybody to be on the same page as to what the findings represent, and also allows very specific criteria for next steps. So LUNGRADS scores vary from 0 to 4x. 0 is actually a designation where there are findings, but those findings are suspected to be benign, specifically infectious or inflammatory. And then starting with 1, the findings relate specifically to any or the lung or the scan findings related to the risk of lung cancer. So 1 and 2 are basically negative scans, and they will result in a recommendation for a routine annual rescreen. LUNGRADS 3, there are findings, but those findings are considered likely benign, and the recommendation is a low dose CAT scan in 6 months. 4A is suspicious, but at the lower end of the suspicious range. And the recommendation there is a repeat CT in 3 months. And this is all managed automatically through the screening process. So those individual patients will get follow-up scans booked through the screening program at these time points. 4B and 4X are very suspicious, and they result in an automatic referral to a lung diagnostic assessment program. So the radiology report is a synoptic report. It's standardized for all screening sites. And from your perspective, the important part is the impressions section. And that it will include, again, the LUNGRADS score, but also the actionable incidental findings and next steps. So in terms of communications to primary care, there are communication points throughout the process. So primary care provider would receive a communication about patients who self-present, as we mentioned, to request a referral form. And will also receive a non-participation letter if the patient was referred and is ineligible for screening, or if the patient declines screening. The radiology report is sent to the primary care provider. And if there are 4B or 4X findings, there will be a notice sent to the primary care provider about the referral to the lung diagnostic assessment program. And there's also a communication sent if there are incidental findings needing follow-up. So in terms of actionable incidental findings, these, as I don't need to explain, I imagine, are those findings not specifically related to the finding of a lung nodule. They can be in the chest, but they can be, or in the lung, I should say, but can be elsewhere as well. The radiologist, him or herself, isn't able to necessarily interpret or judge the importance of the findings without knowing clinical information. So for that reason, the expectation all along has been that that is managed or followed up by a primary care provider. Now, recommendations have been developed by OHCCO for the perhaps most common actionable incidental findings, and the list of that is there. So as an example, these CAT scans of the chest often or do involve cuts of the upper abdomen. And one of the findings is a indeterminate renal nodule or mass. And these are examples of findings there that would be not actionable and actionable, and for actionable findings, a recommendation about next steps. And again, these are available for those most common incidental findings and can be accessed through the CCO website. So in terms of our local data, and thanks to Sarah for adding these slides to the deck, and this specifically refers to data that has been accrued over the years since implementation of the program in 2021 for the Lake Ridge Hub program. So you can see here that the vast majority are primary care referred, mostly from family physicians, but also from nurse practitioners, and a small proportion are self-presented. This is the depiction of the eligibility rate after referral, after the risk assessment. Again, much higher than we anticipated or was anticipated up front. And these are the summary of the Lung-RADS findings. So these are, again, the findings specific to the risk of lung cancer. The vast majority are 2. So that means essentially definitively benign findings on CAT scan and recommendation for annual rescreen. And you can see that only 2.7% of patients overall are, and this was in Q1, by the way, of this year, only about 2.7% had findings that prompted referral to a diagnostic assessment program. And this reflects the overall number of findings that there are on CAT scan. And again, the majority of patients through the course of their low dose screening will have a finding. The key point here, though, is that not every finding prompts a full workup. And that comes down to the use of the Lung-RADS score and training provided extra training provided to screening radiologists to try and very accurately interpret these findings to make sure that only a small proportion actually undergo intensified diagnostic assessment. And in terms of actionable findings, these numbers vary. In the Q1, it was 6.7%. So these are the percentage of participants who have findings that need to be followed up by primary care. And so finally, talking to patients about screening and other issues. So it's, this comes up obviously because you as a group of primary care providers are educated about the indications for screening, but also because patients, your patients come to you and ask for screening. So it would be important it is important to understand who does and doesn't qualify for screening for the reasons we've talked about. So it is not appropriate for people with suspected lung cancer, obviously, and this is sort of information you already know. But if a patient has any of the common signs or symptoms of lung cancer, diagnostic assessment is appropriate rather than screening. And so as an example, so several examples, I should say. So a 67-year-old who has smoked for over 40 years, has COPD and a family history, and wants to know about, or he's heard of lung cancer screening, but doesn't believe it'll help. So the suggestions would be that the benefits of screening are highlighted, but also the potential harms, and also the fact that this will allow a robust link to smoking cessation, perhaps beyond what's available in the community. Certainly, Zane is at high risk for, or would almost certainly meet the risk assessment criteria for screening, but that it's important that he know that that would be assessed by the screening program. And it's important, again, around the benefit to say that if he meets the eligibility criteria, there is evidence, clear evidence, that having screening will make him less likely to die of lung cancer. And that if he is diagnosed with lung cancer through screening, he is diagnosed at an earlier stage. And the two sort of pivotal landmark studies that are always quoted about the benefits of screening, one from the US and one from the Netherlands, clearly show at least a 20% reduction in mortality from lung cancer in screened populations. So it is a significant benefit in properly selected patient populations. So another example, a 55-year-old who smoked for about 30 years, has a family history of lung cancer, but was not eligible for screening after risk assessment. They're very worried about their risk of lung cancer and their health in general, and would really like to be screened. So we would recommend that it just be reiterated that the reason that he's not a candidate for screening is that his risk of lung cancer is, in the next 6 years, is relatively low, that he can be reassessed for screening in the future, specifically at 3 years, depending on what his specific risk category was, and may be able to access screening at that point. That he be encouraged to access the smoking cessation services that would have been highlighted to him by the program, and that is the best way of reducing their risk of cancer. When their risk is low, the best risk or best way of reducing it further is to stop smoking, and that there are potential harms of lung cancer screening, and in patients in lower risk categories, that harm may outweigh the benefit. So another one, 58-year-old, smoked for more than 30 years, but presents to you with a cough and hemoptysis, and is basically asking about lung cancer screening based on information in public. So obviously screening is not appropriate because he has symptoms suggestive or possibly suspicious for lung cancer. There are evidence-based care guidelines for the management of patients with suspected lung cancer, including consideration of referral for diagnostic assessment at a diagnostic assessment program after upfront imaging. And finally, an Indigenous patient, just to highlight this, smoking for 40 years, some medical comorbidities, and no primary care provider, presents to you in a walk-in clinic. So certainly she does meet the inclusion criteria, the referral inclusion criteria, and likely will have a positive risk assessment. Your options as a walk-in clinic physician would be to refer Edith yourself. That would make you responsible for follow-up of the actionable findings. Or you can encourage Edith to self-present, and she would fall into the pathway of unattached patients. Smoking cessation, again, is crucial for everyone. And as we talked about, particularly a problem in Indigenous populations. It's important to point out that to them that if they do present to a screening site, that they will be offered smoking cessation through the program. And that it is important to understand again about potentially marginalized populations not accessing these services or following recommendations from healthcare professionals. And there are ways to try and improve that trust relationship with Indigenous populations. And there are resources for the public that are available centrally, including through the Central East Regional Cancer Program. And there are very specific resources for Indigenous populations. And again, I mentioned there are smoking cessation services offered through programs for patients who are eligible, but also a number of online provincial and national resources for smoking cessation. And there's also resources for providers around inclusion criteria, the process for risk assessment, and as I mentioned before, resources around recommendations for follow-up of actionable findings. This is the referral form. I'm sure, as I said, many of you have filled these out, and thank you for doing that in the past. These are available online as well. And again, Becky Ray has been instrumental in the success of this program across the region as the regional primary care lead for support of the program, but also support of individual unattached participants. And that's another contact online for questions and additional support. And I think that's it for the presentation. I will stop sharing here.
Thanks, John. You did a great presentation, a great overview of the Ontario Lung Cancer Screening Program. And we're super excited that we're able to extend this spoke site to the northern area of our region. We recognize that Lakeridge Health Oshawa has been the hub site, the main site, the only site accessible to patients for so many years. We're lucky enough to actually have been involved in the pilot and to have been one of those initial sites, but it's really exciting to be able to expand to the northern part of the region. I wonder if there's any questions at all. Feel free to add in the chat or raise your hand. I saw one comment in the chat from Dr. Kazarian just about adding the re-referral criteria to the referral requisition. And Sarah did answer that. We will take that feedback to the Cancer Care Ontario Health team to help with that. And certainly if there's ever any, our team is really fabulous. The Cancer Care Ontario team at Ontario Health is also really fabulous and responsive. So if there's ever any questions or suggestions, please reach out to us because that's what we're here for.
I just see a question or comment, Becky, in the chat. And it says, if a patient is referred to OLSP but does not live near the hub site, are they required to travel to the hub hospital for the low dose CT? Or will the CT be arranged at their home hospital through the program? So for example, Peterborough, PRHC. So is it okay if I just answer that question real quick? So right now there is a requirement to go to an approved hub or spoke site. So right now for us in the region, it's Lakeridge Health Oshawa or Ross Memorial. But our plan and our vision within the Central East is that we have all of our hospital sites on board as approved spoke sites. So that's going to take a bit of time. Like I said, just this month, our first spoke site opened, and we do have a plan to expand over the next couple of years. So right now, the answer is yes. The patient does need to travel, but please know that's our intention to bring the screening close to home to all of our hospitals.
Thanks, Sarah. The other thing I was thinking about just as Dr. Dickey was doing his presentation was around that reassessment. So one of the criteria for reassessment for the patients in the sort of moderate risk, right? So less than 1%, it was a re-refer in 3 years. But in that between 1 and it's 1.7 or 2% risk, a new diagnosis of COPD could trigger a re-referral. So just a reminder to primary care providers that access to spirometry has been greatly improved over the last year through a program called Best Care that is supported by Ontario Health and by the OHTs. I know I can speak to Durham Region specifically. There is several sites that have a community site. So spirometry has been embedded right within primary care so that we can improve access, and respiratory educators have been embedded right within primary care. And so what we can do is we can get that information out, so we can connect with Best Care and share the information with everybody here around all of the Best Care sites that are available in the Central East to support confirmation diagnosis of COPD, which helps to support lung health and lung care.
Becky, we have one more question. So someone's joined us from Timmins, so thanks so much. So 4 hours away from the closest facility, is there a set of guidelines to follow for local low dose CT screening outside of the OLSP? And I wonder for that one, I'm not aware, Allison, but we can certainly connect you with the regional cancer program in your area. And I believe Timmins is the Northeast, so we can definitely make that connection and see if we can help facilitate something for you.
Dr. Dickey, I don't know if you get it, the algorithm that the nurse navigators use, it takes 15 minutes, as you guys saw in Dr. Dickey's presentation, but that is accessible, I believe, online. That is an online algorithm. So I don't know, I mean, it wouldn't be part of a screening program, but if physicians outside of screening, I guess, what are your thoughts on that?
Are you talking about the Tamamagi tool, the risk assessment tool? Yeah, I mean, it's certainly widely available. I don't know if it's specifically sort of laid out in the screening program websites, et cetera, but the tool is available broadly. And I mean, if the question is, could it be applied by a primary care provider to get a sense of whether their patient would pass risk? Is that what you're asking? Yeah, certainly. Yeah, certainly that it would be. I mean, it's a very straightforward set of questions that generate that that risk estimate. And again, if they're 55 to 80 and have smoked for 20 years, and you apply that tool and it's 2% or over, then they do certainly qualify. In terms of the low dose screening or the actual low dose CT, I should say, those the process doesn't support that being done outside of a hub or spoke site, in the sense that it's, as I hope I impressed upon you, that it's crucial the specific scan itself in terms of no contrast and radiation dose, but even more importantly, the use of the Lung-RADS reporting out template, et cetera, that's all used. And so the program doesn't support that being done by radiologists or at sites outside of hub and spoke, which, as Sarah said, unfortunately does mean travel. But and for Timmins, I do think that is certainly to Sudbury. But I'm hopeful, and I obviously can't speak for that program, that they would be anticipating spoke sites from their in their program as well. But certainly we are through Lakeridge looking to expand that. We've been talking about that for a while, obviously, but it's incredibly encouraging that we finally do have a spoke site to provide that scan closer to home. Because I mean, I speak to my patients all the time about screening, specifically those who have been referred to me with lung nodules who ultimately don't have lung cancer. And I do tell them about screening and encourage them to follow up with all of you to get that started. But the travel is a definite barrier. There's no question about it. So I think that, as I said up front in the presentation, the key next steps for the provincial program is to expand the accessibility.
So I just see in the Q&A a question from Manon, and so it's good to see you, Manon, again. So thanks for the great presentation. Is there plans in the near future to see the program extend to those affected by secondhand smoke, even third-hand exposures? So I can speak just from conversations with Ontario Health and open to Becky and John jumping in. Right now, the priority for OLSP is to expand across the province. So opening more hub sites across the province and supporting spoke site expansion. But they have discussed once OLSP is across the province, looking at the evidence for expanded eligibility, including exposures. So do not have a time frame on that, but it's very much going to be based on data and information available. So I don't know if Becky or John, you may have something else to add.
It's a very important question. And there are other patient populations this applies to. For instance, there are ethnic populations at higher risk, including patients who haven't smoked and have no secondhand smoke exposure, Asian females. There are a variety of different patient populations. The question will always be, will they meet the risk assessment criteria? And what that data that Sarah's talking about really is a risk assessment tool outside of smokers. And those things are evolving, including other occupational exposures, potential radon exposure, these other elements that we know increase risk. And also the question in my mind about people who have fully treated cured lung cancer, who are a particular high-risk group that don't qualify for screening. But I would say that although it's going to be looked at, my feeling, my sense, and Sarah and Becky know more about this, likely being involved more intimately, but that the expansion of access will take priority. And there will need to be a reassessment of what that looks like in terms of overall screen volumes and impact on before the criteria are expanded. That's my prediction. Because no matter what other populations we look at, none will be as high risk as smokers. So for now, as we try and improve accessibility, my sense is it's going to be limited to that group. But ultimately, I think these other patient population assessments are going to be more important.
Excellent. Thank you very much. I just want to say a huge, huge thank you to Dr. Dickey for joining us this morning. Fabulous presentation and great information sharing, and to our team for helping to organize this and put this together.
Thanks so much, everyone. Have a great day.